All right, let's move on to our fourth cyanotic heart disease. We have Truncus Arteriosus that's persistent. Do you remember what the Truncus Arteriosus is? It's the embryologic origin of the aorta and pulmonary artery that normally gets divided to separate the two vessels from each other. If it's persistent, that means that the Truncus Arteriosus is still there and never divided. And that's usually due to a problem with the aortic pulmonary septum, which normally divides the Truncus Arteriosus to the aorta and pulmonary artery, and also forms a membranous part of the ventricular septum. So notice that the aortic pulmonary septum fails to divide the Truncus Arteriosus by failing to migrate and twist, and you also get a large membranous VSD. And what's going to happen if you have a persistent truncus? Now you have one trunk overlying both ventricles, and both ventricles will pump blood into the Truncus Arteriosus. So blood can get mixed and you can get cyanosis as a result. So let's take a look at this picture here. When we have the right ventricle and left ventricle, you have a Truncus Arteriosus overlying both. So you have oxygenated and deoxygenated blood both mixing together, and hypooxygenated blood going to systemic circulation and also going to pulmonary circulation. So the major problem here is this mixing of the blood and this large trunk that does not separate the two ventricles' circulations from each other. So what is the problem with this? Can this lead to heart failure? Yes, it can, because both the right and left ventricle are taking the entire preload and pumping it into a high-pressure Truncus Arteriosus, which they have to overcome the valve, and all of the blood is inside this Truncus Arteriosus. Remember, to open a valve, the pressure in the ventricles has to exceed the pressure in the downstream vessel, which is the Truncus Arteriosus here. So there'll be high pressures to pump out into the Truncus Arteriosus. And another thing to notice is that the systemic circulation is purple colored. That means it's hypooxygenated blood. That means that the amount of cardiac demand is going to increase the amount of blood flow, to increase the amount of oxygen to the body. And as a result, these mechanisms will cause the heart to fail. In addition, notice that the pulmonary circulation and the systemic circulation both branch off of the same vessel. Which has lower resistance? Right, the pulmonary circulation. So a lot of blood will go into the pulmonary circulation, come back to the lungs, and add to the preload that's already there in the right and left ventricles, leading to a possible failure. So heart failure is a very common association with Truncus Arteriosus. Now blood flow, we talk about how it's mixed, oxygenated, and deoxygenated, looking at the blue and red lines. And a key thing to notice is that the coronary circulation is also massively affected. Remember, the heart supplies itself with blood. So if the coronary arteries are hypooxygenated with blood, you're going to have decreased cardiac function and damage to cardiac myocytes because they're not getting enough to meet their oxygen demands. And also know that this disease, this Truncus Arteriosus, is associated with DiGeorge syndrome. Very important to know. Now let's talk about some symptoms and signs. So know that the valve of the Truncus Arteriosus can be abnormal. Remember, there's a valve separating the Truncus Arteriosus from the ventricles. So you can get a loud systolic murmur, or you can get a high-pitched diastolic murmur. So this is just like aortic or pulmonary stenosis and insufficiency, just a slightly different location. Mid-left sternal border, you're going to have a stenotic systolic murmur or a diastolic regurgitant murmur. These are good things to know just in case you might run into them on your test. Mild cyanosis, we've already discussed this. The blood mixes in the ventricles and in the Truncus Arteriosus. Heart failure happens. We already talked about this. Here are some symptoms of heart failure. These are all signs of the body not being able to have its demands met by the heart. So the heart can't meet the excessive demands in the body because of the hypooxygenated blood and excessive preload. So you get tachypnea, which can be from poor feed, from a backup of blood, or from not meeting the metabolic demands of the body, causing a dyspnea also. Poor feeding, or diaphoresis. Okay, and these are all signs of excessive sympathetic activity trying to increase the heart pumping action. So this happens in the first few weeks of life. And also you get pulmonary edema because of backup of blood and also excess pulmonary blood flow. And this can be causing a hyperdynamic precordium. Remember, we talked about dynamic precordium means that the heart or the pulmonary vessels underneath the chest are beating in a very hard manner, very intense manner, and that can cause the area below the chest to feel like it's moving up and down. That's a hyperdynamic precordium. Increased pulse pressure with bounding pulses. Because you have so much blood being pushed forward from the right and left ventricle, you have a huge systolic pressure and a decreased diastolic pressure because the valve closes and now a lot of blood will move into the pulmonary circulation. So that'll cause an increased systolic pressure and a decreased diastolic pressure, resulting in increased pulse pressure. So increased systolic, decreased diastolic. Loud single S2, remember there's only one valve, so that's pretty self-explanatory. And you also get an ejection click. Remember, you need to have a large amount of pressure to open up the valve and that can cause a click because of the high pressure behind the valve. And also you get a flow murmur as well over the apex, over the mitral valve, due to increased pulmonary blood flow going back to the left atrium. Now for diagnosis. Like always, we start with stabilization, then we move to chest x-ray and EKG, and then we move to echocardiogram. So what's the chest x-ray going to show? We talked about how the heart's very likely to fail, cardiomegaly, and you have a lot of blood going to the lungs because there's only one truncus arteriosus, and blood can go in the lower resistance pathway. EKG shows both sides of the heart being enlarged, and echo is the best test for this condition. Treatment: always do medical treatment of heart failure symptoms and stabilize the infant before surgery to reduce mortality. And one important question to go back to is, would prostaglandins be helpful in this patient's condition? No, it wouldn't. You don't need a PDA if the pulmonary artery and the aorta are already connected as a truncus arteriosus. So this is a condition where prostaglandins would actually not be useful. Alright, key thing to know.